Good morning, everyone. My name is Lakshita. म्यूट करना है फिर से मैंने स्टार्ट कर दिया। Good morning, everyone. My name is Lakshita Gautam, and my topic of presentation is electrolyte imbalance and its psychiatric implication. My moderator is Dr. Ayushi Gira ma'am. What is electrolyte imbalance? When you have too much or not enough of certain minerals in your body that cause electrolyte imbalance. Electrolyte imbalance itself manifests as psychiatric symptoms like depression, seizures, anxiety, etc. The various important electrolytes are sodium, potassium, calcium, and magnesium. Electrolyte imbalance commonly includes sodium dysnatremia and dyskalemia. Dysnatremia further includes hyponatremia and hypernatremia, and dyskalemia includes hyperkalemia and hypokalemia. Now the causes of hypernatremia and hypernatremia. Causes of hypernatremia is diuretics, gastrointestinal loss, diabetic ketoacidosis, hypothyroidism, beer potomania, water intoxication, psychogenic polydipsia, and CCF, cirrhosis, and nephrotic syndrome. Causes of hypernatremia is diuretic, gastrointestinal loss, diabetic ketoacidosis, diabetes insipidus, hypodipsia, and excessive IV administration of sodium containing fluids and mineralocorticoid excess. Causes of dyskalemia. The causes of hyperkalemia is high dietary intake of food rich in potassium, excessive iatrogenic potassium supplements, acute kidney injury, CKD, drugs like ACE inhibitors, ARBs, NSAIDs, spironolactones, insulin deficiency or resistance, metabolic acidosis, medications like beta blocker and digoxin. And the causes of hypokalemia is insufficient intake of potassium, bulimia, starvation, dementia, alcohol excess, medication like diuretics, laxatives, GI loss like vomiting and diarrhea, renal losses, dialysis, and medication like insulin, thyrotoxicosis, and alkalosis. Now let's discuss the psychiatric implication of these electrolyte disturbances. First, let's start with the hyponatremia. What is hyponatremia? When serum sodium level decrease below the level of 135 millimole per liter. Once the serum sodium level falls below 125 millimole per liter, neuropsychiatric symptoms predominate. The clinical manifestations of hyponatremia are largely due to osmotic swelling of brain cells, resulting in neurological and systemic symptoms like lethargy, restlessness, headache, confusion, behavioral changes, seizures, irritability, psychotic and manic behaviors. What is hypernatremia? When serum sodium level more than 145 millimole per liter. At the sodium level more than 160 millimole per liter, 1/4 of patients will have neuropsychiatric signs and symptoms, which includes increased irritability and hyperactivity, acute organic syndrome, ranging from mild impairment in cognitive function to somnolence and stupor, seizures, hyperactive dependent reflexes, and non-specific tremors. Psychiatric patients show a vulnerable cohort for hypo and hypernatremia. For example, abuse of laxative and diuretics in eating disorder cause increase and decrease in sodium level by GI loss and hypodipsia. Danish register-based study of over 60,000 individuals compares the risk of hyponatremia in people prescribed or not prescribed antidepressant. It is seen more in people taking antidepressant. And the effect is more commonly seen with SSRIs within 2 weeks of treatment and venlafaxine. Lower risk shows by with mirtazapine and neomycin. Nephrogenic diabetes insipidus occur when patient is prescribed lithium, which may cause hypernatremia. Psychogenic polydipsia cause electrolyte imbalance, which leads to severe mental illness. Hypokalemia. Hypokalemia when serum potassium level below 3.5 milliequivalent per liter. Hypokalemia has a prominent effect on cardiac, skeletal, and intestinal muscle, and also affect the nervous system. The following are neurological manifestation of hypokalemia includes delirium, hallucination, depression, and rarely psychosis. Hypokalemia. Hyperkalemia when potassium level more than 5 milliequivalent per liter and organic brain syndrome is most frequent manifestation of hyperkalemia, and the signs and symptoms includes weakness, dysphagia, dysarthria, and in some rare cases, paralysis may occur. However, the paralysis may not be seen because death from cardiac arrest may occur before muscle weakness become evident. Thank you.
Good morning to all. I am going to present on the topic psychiatric implications of GI symptoms, and my moderator is Dr. Sarthak. There is an intimate relationship between GI tract and psyche. Example, stress, anxiety may modulate GI function like diarrhea, bloating, nausea, and discomfort. Inflammatory bowel disease and psychiatric symptoms. Two major types of inflammatory bowel diseases are Crohn's and ulcerative colitis. Relationship between psychiatric illness and inflammatory bowel disease is incompletely understood. Evidence suggests that anxiety and depression are more common in patients with IBD, and the symptoms of these affective disorders are more prominent during period of relapse. Nevertheless, there is paucity of studies that objectively investigate the hypothesis that anxiety and depression are risk factors for IBD. However, comorbid anxiety and depression seem to worsen the natural history of IBD once it is developed. Psychosocial therapies in IBD. Miller and Burwell administered gut-focused hypnotherapy. Hypnotherapy is Hypnotherapy is a changed state of awareness and increased relaxation that allows for improved focus and concentration. They concluded that hypnotherapy might represent a promising adjunctive treatment of IBD. A recent study identified 7 randomized controlled trials for mind-body interventions such as lifestyle modifications, hypnotherapy, relaxation training, mindfulness, which may display a degree of efficacy in treatment, although the results were heterogeneous and at significant risk of bias. Irritable bowel syndrome. Main clinical features of IBS are alteration in stool frequency or consistency and relief with defecation. 4 types: IBS with constipation, IBS with diarrhea, IBS with alternating bowel habits, IBS unclassified. About half of the patients with IBS suffer from psychological comorbidity between depression, anxiety, and hypochondriasis. There is evidence has demonstrated that psychosocial treatment are effective in symptom reduction in IBS. Given the relatively high burden of side effects associated with more traditional pharmacological therapies, hypnotherapy represents an excellent treatment option. Functional abdominal pain. Functional abdominal pain syndrome is characterized by frequent or continuous abdominal pain associated with degree of loss of daily activity in absence of change in bowel habit. There is absence of international consensus with respect to optional clinical management of FAP due to paucity of well-designed randomized control trials for therapeutic interventions. Functional chest pain. Functional chest pain of presumed esophageal origin is characterized by recurrent unexplained chest pain felt in midline. 3 mechanisms suggested for that: heightened sensitivity to esophageal balloon distension given by Richter et al., stress-responsive physiological systems encompassing ANS and HPA axis are implicated in a number of functional disorders, including FCP. Stress-responsive systems act as brain-body interfaces and are critical components of psychosocial adaptation in response to stress. 61% of patients with FCP have demonstrable degree of psychological comorbidity, which itself may enhance esophageal perception. Role of psychiatrist in managing functional GI disorders. Most of the treatment options for these conditions involve the use of psychotropic medications and psychotherapeutic methods familiar to psychiatrists. There is hence considerable benefit for psychiatrists in engaging more actively in the care of this often misunderstood and untreated patient group. The somatic representation of depression in functional GI disorders and the failure to diagnose it because of presentation bias. When a patient primarily presents with physical symptoms and the apparent absence of psychiatric symptoms. In an international study of 1,146 patients with major depression, only 69% reported physical symptoms. A similar study showed that in patients presenting with solely somatic complaints, only 22% were correctly diagnosed with anxiety and depression. This is in contrast to patients who presented with psychosocial problems, where 77% were correctly diagnosed with psychiatric conditions. Novel neurotransmitter and functional brain imaging research implicate dysregulation of gut-brain axis at the peripheral, spinal, and cerebral levels, all of which may contribute towards the symptoms of functional GI disorder. Neurotransmitters such as serotonin, norepinephrine, corticotropin-releasing hormone, and opioids modify both motility and sensation in the gut. Physical symptoms are a potential surrogate marker of psychosocial distress. Higher in number of physical symptoms, the greater the degree of psychosocial distress. Recent evidence suggests that up to 1 in 8 patients with functional GI disorder are offered an antidepressants. In a Swedish study, after antacids, antidepressants were the most commonly used drug category reported by patients with IBS. Patients with functional GI disorder commonly give personal histories of major stressful life events, including sexual abuse, personal losses, separation, or early histories of deprivation. Conclusion: the gut and the brain are intimately linked, and any disorder in one can manifest in the other. Therefore, psychiatry can play a pivotal therapeutic role in management of patients with GI disorders.
This is one article that you've taken for your presentation.
Sir, ये Kaplan and Fedoxil.
उसमें आप एक बोला ना साइकियाट्री में साइकियाट्रिस्ट को देते हैं and psychiatric hypnotherapy is more beneficial. Yes, yeah. In all the psychotropic medication and psychotherapeutic methods familiar to psychiatrists, there is hence considerable benefit for psychiatrists engaging more actively in the care of this. Psychiatrist को क्या फायदा होगा उससे?
Patient.
आपने जो ये लिखा है लिया है ना आर्टिकल देखो there should be bad job. There are in any field there are proponents to certain say treatment methods, okay, who actively believe in that, and then there are people who believe in other treatment methods. Okay, there are some researchers who very strongly believe in ECT, and they have written strong articles supporting ECT. Okay, there are then authors who have strongly believe in psychotherapy, and they have given strong evidence to psychotherapy, right? So from your this thing, it appears that somebody who is very, you can say, a proponent of hypnotherapy has written this article. Okay, hypnotherapy अभी recently बहुत ज़्यादा यूज नहीं होती थी 80s 90s में, पर जो आजकल हम लोग क्या कहते हैं किसी उसमें नहीं है ट्रीटमेंट गाइडलाइंस. ओके, हिप्नोथेरेपी हर किसी की नहीं हो सकती, हिप्नोसिस ही नहीं हो सकता. ट्रीटमेंट जैसे अगर इफ यू आर गिविंग सम ट्रीटमेंट, फॉर एग्जांपल इफ यू आर डूइंग एन appendix operation for a patient, so you should be able to do it for all the patients. If you are saying that only 70% of my patient I can put under anesthesia, 30% will miss out. So hypnosis itself, not everybody can be hypnotized. Okay, that is one. People who are more suggestible are more prone to hypnosis, and then these are also people who show more of placebo response. Okay, so the crux of evidence-based psychiatry, which we say, is placebo versus that treatment. Okay, so whether just the procedure of somebody undergoing hypnotherapy, that I have undergone hypnotherapy, that gives somebody a feeling of well-being and it releases the symptoms. So for any of the somatoform disorders, it is also known that whenever they go to a new therapist and some new treatment is tried, Initially, they will have great effect. Wonderful. Within 2 days, they will say that I'm cured. But the same thing, after 1 month, 2 months, they stop having that effect and then they will go doctor. Okay, so any therapy you start will initially show remarkable. So you have to have a placebo arm and a control arm, and then you see whether this therapy works in long term, how much this therapy works. Okay, so all these things before you build evidence. Okay, certainly hypnotherapy will work in this patient, but the longevity of it, okay, that is remain, right?
Good morning, everyone. My name is Mansi, and today's topic is liver function test and its relevance in psychiatry. My moderator is Dr. Asta Jain. LFT can be used to detect the presence of liver disease, distinguish among different types of liver disorders, gauge the extent of non-liver damage, and follow the response to treatment. Classification of liver function test is based on the major function of liver. Number 1 is excretion by measuring bile pigments, bile salts. Number 2 is serum enzymes, which includes transaminases, ALP, 5-nucleotidase, LDH isoenzymes. And number 3 is synthetic function by measuring prothrombin time and serum albumin. First of all, serum bilirubin. It reflects the liver ability to take up, process, and secrete bilirubin in bile. And the normal value of total bilirubin is 1 to 1.3 milligram per dl. Direct bilirubin is 0 to 0.3 milligram per dl. Indirect bilirubin is 0.2 to 0.9 milligram per dl. Serum enzymes. It is grouped into 2 categories. Number 1, based on elevation in enzymes due to damage to hepatocyte. It basically includes aminotransferases, which are of 2 types, AST and ALT. AST is also known as SGOT and ALT is also known as SGPT. अगर हम एक्यूट हेपेटाइटिस की बात करें तो जो नॉर्मली हमारे ALT ज़्यादा इंक्रीज होते हैं कंपेयर टू AST. जो इसकी नॉर्मल रेंज होती है 10 to 40 इंटरनेशनल यूनिट पर लीटर, पर एक्यूट हेपेटाइटिस में ये 1000 तक इंक्रीज हो सकते हैं, ऑफ मोर देन 1000. अगर हम एल्कोहल हेपेटाइटिस की बात करेंगे तो AST इज मोर इंक्रीज देन ALT. अगर उसकी रेशियो मोर देन 2:1 है तो वो सजेस्टिव ऑफ एल्कोहलिक लिवर डिजीज होगा, पर अगर मोर देन 3:1 है देन इट इज डायग्नोस्टिक ऑफ एल्कोहलिक लिवर डिजीज. क्रोनिक हेपेटाइटिस में ALT is more than AST, normally more than 5 of normal of upper limit value. Enzyme elevation reflects cholestasis are alcoholic alanine phosphatase, 5-nucleotidase, gamma glutamyl translactidase. Normal values are normal values of ALP is 40 to 140 international unit per liter. GGT is 5 to 40 and 5-nucleotidase is 2 to 15 इंटरनेशनल यूनिट पर लीटर. जो ALP होता है वो मोर देन 5 अपर लिमिट से ज्यादा इंक्रीज हो तब जाके सिग्निफिकेंट है, अदरवाइज वो नहीं है. पर वो सिर्फ हमें सजेस्ट करेगा. कंफर्मेशन के लिए GGT यूज करते हैं जो लीवर एंजाइम स्पेसिफिक है कोलेस्टेसिस के लिए, और हम 5 अल्फा न्यूक्लियोटाइडेज भी यूज कर सकते हैं, बट दैट इज नॉट स्पेसिफिक फॉर लिवर फंक्शन टेस्ट. Now synthetic function, इसमें हम it includes total plasma protein, albumin, globulin and albumin to globulin ratio. Normal values are of serum protein is 80 to 110 milligram per dl, albumin is 40 to 50, globulin is 25 to 35, ratio is 1.5 to 2.5 milligram per dl. Now clotting factors. All clotting factors are produced exclusively by liver except for the factor 8, which is produced by endothelial cells. It also gave estimation of liver functions for liver function tests. Actually, these tests individually are not very specific or sensitive, so we have to take them most, मतलब कि हमें इनमें से बहुत सारे को लेना पड़ेगा साथ में कुछ डायग्नोसिस तक पहुंचने के लिए। एक कोई भी फंक्शन किसी भी चीज को स्पेसिफिक नहीं करता है कि वो लिवर डिजीज है कि नहीं, सिर्फ हमें एक हिंट देता है आगे हमारी फर्दर डायग्नोसिस के लिए। This table summarizes whatever that I've explained previously. Now, drug-induced hepatic damage. Hayes rule tells कि अगर ALT is more than 3 times of upper limit combined with serum albumin, which is 2 times of upper limit, it to access the hypotoxicity of new drugs. Drug-induced hepatic damage could be due to drug direct dose-related hepatotoxicity or hypersensitivity reactions. Risk factors are increasing age, female gender, alcoholic consumption, co-prescription of enzyme-inducing drugs, genetic predisposition, obesity, pre-existing liver disease. When monitoring LFTs, ideally LFT should be measured before treatment to know the baseline values, of liver functions. If liver function is equal to more less than 2 अगर increase है, तो that is not significant. If it is more than 3 times fold, or it continue to rise or accompanied by clinical symptom, then it is suspected to be due to drugs. Most drug-related LFT elevations occur early in the treatment or are transient. They indicate adaptation to liver to the drug rather than damage per se. Now, the relevance of LFT in psychiatric drugs. Antipsychotic drugs in 1/3 of patients prescribed with antipsychotic medication have at least one abnormal LFT, or and in 4% at least one LFT is elevated 3 times above the upper limit of normal. Transaminases are mostly affected, and it occurs within 1 to 6 weeks of treatment initiation. Clinically significant hepatic damage rarely occurs. Now, drugs, aripiprazole, no drug reduction required in moderate to mild cases, but caution required in severe cases. Clozapine, contraindicated in active liver disease. Olanzapine, dose-related transient asymptomatic elevation in ALT and AST are very common. Paliperidone, rising transaminases and gamma GT reported. Haloperidol, isolated reports of cholestasis, acute hepatic liver hepatitis and abnormal liver function tests are reported. Sedatives, Z-drug. Z-drug reduce initial doses in mild to moderate impairment, avoiding severe impairment. Melatonin, manufacturers recommend avoiding in liver disease. Promethazine, manufacturers recommend caution in liver impairment. Benzodiazepines, serum enzyme elevations are uncommon and liver injury very rare. Antidepressants, 0.5 to 3% develop asymptomatic mild elevation of hepatic transaminases. Onset is between several days to 6 months of treatment initiation. Elderly are more vulnerable. Clinically significant liver damage is rare. Fluoxetine, asymptomatic increase in LFT found in 0.5% of healthy adults. Rare cases of hepatitis reported. Mirtazapine, mild asymptomatic increase in LFT seen in healthy individuals. SSRIs, selective serotonin reuptake inhibitors, rates LFTs and are rare cases of hepatitis have been reported with paroxetine. Citalopram, acetylopram, and paroxetine have minimal effects on hepatic enzymes and may be the SSRI of choice. Tricyclics all are associated with rates LFTs and rare cases of hepatitis. Venlafaxine and desvenlafaxine, dose reduction of 50% advising mild to moderate liver impairment. Rare cases of hepatitis reported. Milnacipran, increased liver enzymes and hepatitis have been reported. Discontinue use if jaundice or liver function dysfunction occurs. Now, mood stabilizers. Carbimazepine, avoid using acute liver diseases. Stop if LFT deteriorates. Associated with hepatitis, cholangitis, cholestatic, and hepatocellular jaundice and hepatic failure rare. Lamotrigine, extreme caution advised, particularly in women, children, and if co-prescribed with valproate. Lithium, not metabolized by liver, so damage reduction not required as long as liver renal function is normal. Asymptomatic and transient LFT abnormalities reported. Valproate, dose reduction with close monitoring of LFT in moderate impairment. caution advised. Contraindicated in severe or active hepatic impairment or family history of severe. Now, psychotropics that are recommended in hepatic impairment are for antipsychotic, sulpride and amisulpride, antidepressant, paroxetine, sertraline, citalopram, or vortioxetine. For mood stabilizer, lithium, and sedative is lorazepam, oxazepam, or temazepam, and zopicon. Reference.
Just elaborate one thing. Direct and indirect.
जी
पता है इसमें क्या डिफरेंस होता है?
जी सर जी सर सर जो हम अनकॉन्जुगेटेड और जो इनडायरेक्ट बिलिरुबिन की बात करते हैं वो हमारी हिमोलिसिस की कंडीशन में इंक्रीज होता है जब हमारा जो सर मैंने सिर्फ नॉर्मल वैल्यूज लिखी है यहाँ पे जी
डायरेक्ट क्या होता है?
जी जो डायरेक्ट होता है वो अनकॉन्जुगेटेड बिलिरुबिन होता है जो सिर्फ लीवर सिक्रीट करता है मतलब जो लीवर में मेटाबोलाइज नहीं होता हमारी बॉडी से जो आरबीसी लिसिस होती है जो बिलिरुबिन बनता है जो बहुत ज्यादा मतलब लिसिस होती है आरबीसी के जब जो बिलिरुबिन हमारी बॉडी में इंक्रीज होता है वो अनकॉन्जुगेटेड और इनडायरेक्ट बिलिरुबिन होता है जो डायरेक्ट बिलिरुबिन होता है वो दो वजह से इंक्रीज हो सकता है हेपेटिक कॉजेस के कारण और आगे फर्दर एक्स्ट्रा हेपेटिक के कारण तो वो सर वो वाला डायरेक्ट बिलिरुबिन होता है जो कॉन्जुगेटेड बिलिरुबिन होता है
Conjugated means it is expression के लिए ready है
जो अभी वो हुआ नहीं है मेटाबोलाइज तो
conjugated to hemolysis से पड़ेगा
जी जी
so if it is in, which is increased direct or indirect hemolysis
सर इनडायरेक्ट जी
indirect is increased in hemolysis डेल्टा बिलिरुबिन पता है आपको?
यस सर
क्या होता है?
सर वो डेल्टा बिलिरुबिन जो हमारी बॉडी में डिटेक्ट नहीं होता बिलिरुबिन सर जब वो मतलब उसकी ना जो हाफ लाइफ होती है ना वो थोड़ी ज्यादा होती है जो नहीं जो डिटेक्ट मतलब कि जो हमारी बॉडी में बिलिरुबिन नहीं भी है मतलब ज्यादा डिसफंक्शन नहीं है फिर भी हमारी बॉडी में काफी टाइम तक जो बिलिरुबिन रहता है क्योंकि उसकी हाफ लाइफ ज्यादा होती है तो वो डेल्टा बिलिरुबिन होता है जी
नॉट क्लियर अबाउट डेल्टा बिलिरुबिन मैसेज वो पता है? ठीक है तो नाइस रिजल्टेड वेल if you can just repeat that ALT and AST in hepatitis and in alcoholic hepatitis and in other hepatitis
जी सर AST और ALT दो हमारे ट्रांसएमिनेजेस है जो ALT है दैट इज स्पेसिफिक फॉर लिवर डिजीजेस जो AST है वो मसल डिजीजेस में इंक्रीज हो सकता है जो कार्डियक डिसफंक्शन जैसे कि MI हो गया उसमें भी इंक्रीज होता है मतलब कि वो लिवर के लिए स्पेसिफिक नहीं है अब हम तीन हेपेटाइटिस की बात कर रहे हैं यहाँ पे एक एक्यूट हेपेटाइटिस की एक अल्कोहलिक हेपेटाइटिस की और क्रोनिक हेपेटाइटिस की अगर हम एक्यूट की बात करेंगे तो जो नॉर्मल लेवल है वो 10 to 40 इंटरनेशनल यूनिट पर लीटर होता है इन दोनों के लिए अगर वो मोर देन 1000 हो जाए तो एक्यूट हेपेटाइटिस की तरफ ज्यादा इशारा करती है वो चीज जिसमें ALT AST से ज्यादा ही होता है जैसे कि कोई वायरीमिया हो गया कोई टॉक्सीमिया हो गया हाँ जी अगर हम अल्कोहलिक की बात करेंगे तो AST इज मोर देन ALT उसमें भी अगर मोर देन 2:1 की रेशियो है तो वो सजेस्टिव है डायग्नोस्टिक नहीं है और अगर 3:1 की रेशियो है देन इट इज डायग्नोस्टिक ऑफ अल्कोहलिक लिवर डिजीज अगर हम क्रोनिक की बात करेंगे तो उसमें मोर देन 5 जैसे कि नॉर्मल लिमिट हमारी 40 है तो 200 तक उसमें इंक्रीज होते हैं जो लिवर एंजाइम्स हैं जी 4 to 5 टाइम्स और इसमें भी हम ALT को AST से ज्यादा मानते हैं पर AST भी अगर क्रोनिक डिजीज में अगर AST ज्यादा ALT से है तो हम सिरोसिस की तरफ वो चीज ज्यादा इंडिकेट करती है क्योंकि जो साइनसोइडल होते हैं वहाँ पे AST एब्जॉर्ब नहीं होता तो उसका लेवल जो एल्कलाइन फॉस्फेटेज है सर वो भी नॉन स्पेसिफिक है क्योंकि वो बोन्स पे रिलीज करती हैं प्लेसेंटा भी इंक्रीज करता है लिवर भी इंक्रीज करता है अगर वो मोर देन 4 है तभी वो सिग्निफिकेंट है वो सजेस्टिव है वो डायग्नोस्टिक नहीं है तो उसके
क्या ऑब्स्ट्रक्टिव जॉन्डिस और इसमें कुछ कर सकते हैं?
हाँ वो कोलिस्टेसिस को जो ऑब्स्ट्रक्टिव जॉन्डिस होता है जो कोलिस्टेसिस होता है उसको सजेस्ट करता है और उसको कंफर्म करने के लिए हम फिर GGT कराते हैं जो स्पेसिफिक लिवर डिजीज है
जो है ना वो जो बिलियरी स्ट्रक्चर है उसको डैमेज होता है तब अल्कलाइन फॉस्फेटेज
जी ऑब्स्ट्रक्टिव वाली साइड पे हम जी कोलिस्टेसिस पे
जो एंजाइम का है अल्कलाइन फॉस्फेटेज स्ट्रक्चरल
डैमेज को बताते हैं जी सर।
जैसे अगर ऑब्स्ट्रक्टिव होगा एक्यूट हेपेटाइटिस में दोनों बढ़ सकते हैं ना, ठीक है जी। अल्ट्रासाउंड फाइंडिंग नहीं पाई हमने, ठीक है, इट्स ओके, यू डिड योर जी। Anybody has questions?
For all the GI symptoms, nausea, vomiting, function, constipation, and also irritable bowel syndrome. So according to that criteria, there should be abdominal pain, which should be 1 day per week for the past 3 months, and which will be associated with alteration in bowel habits and stomach criteria. Also, known for criteria also has criteria for cannabinoid-induced hyperemesis.
Cannabis-induced hyperemesis.
Yes, sir. Cannabis hyperemesis.
Okay. Yeah, three. Yeah, two. Perfect. Hyponatremia. देखे भी हमने पेशेंट हाइपोनेट्रीमिया, क्या मैनेजमेंट होता है उसके लिए?
Mild cases is above 125 to 155. For example, being salt capsule or any alcohol. So,
target. The rapid correction of sodium is not recommended. Rapid energetic, even if it is 100, rapid correction of sodium is not recommended. Okay, 5 to 10 milligrams per day to go for, because it can lead to pontine malmosis. Hyponatremia can also precipitate pontine malmosis, but rapid correction is also say correlated with pontine malmosis. Okay, that is one thing. Mostly we see mild cases about 125 to 135 just by oral correction. पहले यहाँ पे नहीं मिलती है salt tablets आते हैं, salt tablets just increase oral intake. तो उसमें आपको IV saline लेने की जरूरत नहीं है. Hypertonic saline is normal saline does not increase that much sodium level. Okay, मतलब जो है वैसे कर सकता है क्योंकि उसका वैसे ही कम है. It is normal saline is supposed to, because you give normal saline patients also do it self. then इसका सोडियम बढ़ा देता है. वो तो जो आपका नॉर्मल कंसंट्रेशन है प्लाज्मा का उसी कंसंट्रेशन में 0.9 पे, so normal saline is not that effective in correction. Okay. और पोटेशियम में जैसे बताया hyperkalemia can lead to cardiac arrest, so ECG is more recommended in monitoring if you have potassium problems, because why? Potassium is basically an intracellular, it is an intracellular electrolyte, so plasma में इतना जल्दी reflect नहीं करता. Any change will not show, like even if there is hyperkalemia, so it may not manifest immediately in the plasma. So ECG monitoring is the one that is required if you're suspecting hyperkalemia or say problems. Right? And insulin कैसे help करता है? Insulin is recommended to be insulin can. All these are like, of course, if you basic things you should know, because you can help fasten the management. आपका पेशेंट है, आपको पोटेशियम लग रहा है तो कहा लो आप ECG अपनी तरफ से, क्योंकि फिर मेडिसिन वाले आएंगे, फिर बोलेंगे तब करोगे, समटाइम्स इन दीस केसेस it can be grave problem.
सर डेल्टा बिलिरुबिन होता है, जो बिलिरुबिन की हाफ लाइफ होती है 4 डेज होती है नॉर्मली। अगर डेल्टा बिलिरुबिन होता है उसकी 14 to 21 डेज होती है हाफ लाइफ। तो वो बॉडी में ज़्यादा टाइम पे डिटेक्ट होता है, तो उससे हमें लगता है कि रिकवरी लाइक है पेशेंट का, लेकिन वो बिल्कुल भी नहीं है, तो वो डेल्टा
मतलब the patient is in the bilirubin is more, but the say it is he's in recovery phase. Gastric symptoms है, I think that it was a little difficult topic, but आजकल तो जो है gut and brain का जो क्या कहते हैं connection है, there's a lot of work going on. Serotonin सबसे ज़्यादा gut में होता है, more than brain. Okay, so say SRIs may have an effect there. Gastric effect के कुछ ज़्यादा मतलब side effects ज़्यादा मिलते हैं. There is a hypothesis. It's a hypothesis. One of the hypotheses that the antidepressants work by changing the gut flora. One of the hypotheses. Okay. So what actually is there, we don't know. They are effective. ठीक. इसके बाद